Well, hello everyone. Welcome back to another episode of Research Works podcast. I hope that you have all been enjoying our conference series. It's probably been our biggest month, and it sounds like everyone has been catching up, listening to all of the episodes. There were so many different topics that we covered, and I certainly learned a lot from that conference series and already putting things into place, which is the whole idea of these things, right? So I hope you've been enjoying it. We have a great episode ahead for you today. Today I am flying solo, but I've got so many questions that I think I'll take the space of two hosts today because this isn't an area that I'm very interested in. In fact, I got a bit of a heads up about this article last year when I saw it pop up. I was pretty quick to contact our guest today, which is Dr. Jason Howard. Welcome to the pod, Jason.
Thanks. It's so great to be here. Thanks for your invitation.
It is so great to have you here. Your article was hot off the press. It is something that I think we've been thinking about for a little while, and really interested to hear about the background and the story behind this. And thank you so much for staying up. Like, we realize our time difference isn't particularly convenient. It is an 11-hour difference. So morning for me, night for you. And as you said, your kids are all in their rooms, relegated into their rooms for a little while so that we can have a chat today. So thank you to your family for accommodating this, Jason.
Yeah, I just hope my son doesn't get too hungry and come bust out here and interrupt us, but I'm sure he won't.
Well, maybe, it'd be stealth, hopefully. But thank you so much to everyone. Look, a bit of a background here. We actually met very briefly in Heidelberg. We met at a dinner where Ginny Paleg, as a lot of people may know, Ginny has been on the podcast before. She organised a dinner while we were there for the EACD conference. It was this long table, Wade Schrader and Carol Schrader on one side of this very long table, and I was on the other, and I only heard about the conversations you guys got to have with a lot of my colleagues. So I'm very excited that I get to speak with you now. I feel like this is my turn to have you one-on-one. We're talking about the article that was recently published in the Journal of Bone and Joint Surgery. So it's open access, everyone, something that you can definitely get a hold of. And it is titled Hip Displacement in Spastic Hemiplegia, Increased Risk with Hip Internal Rotation and Adduction Irrespective of Sagittal Gait Pattern. The title has it all there, Jason. So before we launch into all things about this paper, let me give everyone a bit of a background about who you are. So Professor Jason J. Howard is a Royal College and American Board certified pediatric orthopedic surgeon and internationally recognized expert in cerebral palsy and hip surveillance. He currently serves as division head of orthopedic surgery at the IWK Health Centre and professor of surgery at Dalhousie University in Halifax. With advanced training in gait analysis and international fellowships, Dr. Howard's research is vital to the development and precision of hip surveillance protocols, delivering practical, evidence-based strategies for health professionals working with children with cerebral palsy. A lot there. Congratulations. I love everything about that bio. It sounds like you've been rather busy and also traveling a lot.
Yeah, I could say that I'm a global citizen for sure. It's been a journey.
Love that. It's great. And I think that's what this profession has allowed us to do. You know, if you're curious, you often want to know what's happening in different parts of the world, not just from food and culture, but also from a professional standpoint, which leads me into the icebreaker question for today. So you're well-traveled, global citizen, as you say, but I'm curious, which country were you actually born in, and what is it about that country? Or what is it about your personality that best reflects the country that you're born in? What would that be, Jason?
Well, I was born in Canada, so I'm Canadian. And I would say that the thing about me that most reflects where I'm from is I think that I'm a fairly nice person, and Canadians are known
very well known for being
their
nice,
politeness and being nice, and I think that I've kept that reputation going. I have my moments where I feel like I deviate from the path, but mostly I think I'm pretty nice most of the time.
I love that. It is so true.
And I like snowshoeing.
You like snow what, sorry?
Snowshoeing. And I like
What's
snowshoeing.
snowshoeing? Tell me what that is.
Oh, I guess that's right. You wouldn't see that in Australia. It's when you get snow, when you get a blanketing of snow, which we've had here over the last winter, and even just a few days ago, we had some. When you go out for a walk, you can go down through the deep snow with your boots on. But if you have a snowshoe, which looks like a tennis racket that you put on your boot, you can walk on top of the snow. Right? So the Inuit people invented that. And so we've adopted it. And it's a lot of fun. It's a great way to get out, get some exercise in the wintertime, particularly if you're someone like me who's not a good skier and breaks a lot of bones. So it's a safer sport that way.
I did not realize that's the name that it is given, because I think that's such a brilliant way to, I can't help but to think of how that alters your gait pattern, because we often do try to mimic in having more of a longer lever at the front to help with that ground reaction force for knee extension. So I love that. It's great, and I think talks nicely about what you can do in Canada. I love that. Ed, I'm going to go over to you because we haven't really included you in these icebreakers. And I did hear you complain about that not that long ago. So we're going to include you here today. So which country were you born in? And what is it about you that best reflects the country you were born in?
Well, despite the crocodile hunter accent, I'm actually a Dutchman. So I was born in the Netherlands. I still travel on a Dutch passport. Uh-huh. And I still dress in orange every 2 to 4 years, depending on how often we make these international tournaments. And football is still with a round ball for me. And I think what might mark me as a Dutchman might be, let's say, a confidence that borders on arrogance sometimes. I'm allowed to say this, I'm a Dutchman. The other thing is I read like menu lists from right to left to make sure I know the price before I'm ordering the food. But I would just say maybe it's just my forthrightness. So I think I still carry that into Australian culture, and it clashes sometimes. Whereas I think I can speak my mind, and my family doesn't think anything of it, but obviously other Australians do. So
it is true. I think there is a confidence there, but I love that you have said that there is this confidence that borders on arrogance sometimes. And reading the menu from right to left.
From my perspective.
That's good. That's really good.
Well, how about yourself, though?
Okay. So
are you sure it's only borders?
We'll see by the question at the end, Jason. I think you'll be able to judge the question at the end. Let's see.
Well, that's why my segment is called Tell Us Ed. Like I wanted to put my name into the segment. Slowly taking over the show.
Slowly taking over, yeah. It's a common joke, but it might actually truly happen one day. Let's see.
But Dana, where are you from?
Yes. Okay, so despite the fact that I asked you the question about what snowshoeing is, I just never knew that was the name for it. I was also born in Canada. I'm from Calgary, Alberta, right in the middle. Yes.
Are you?
Yes. And I was there till I was about 11 years old. So I moved to Australia with a very Canadian accent, and then now it's very Australian. But every now and then, depending on who I speak with, a little twang will come out, I think, and I've been told that. Anyway, so I would say what makes me very Canadian still, so I still am a Canadian citizen, is my absolute love, because Calgary was like rodeo center, right? And I didn't realize any different from there. So I love my pancakes with maple syrup and bacon. And I actually love a good Western. And I didn't realize how much I love Western-themed movies, TV shows. And I think it just resonates because everywhere I went in Calgary, especially around Stampede time, there were literally hay bales everywhere. And we would stop school segments to have pancakes with maple syrup and bacon. And I love my maple syrup. So I think that probably describes me most as a Canadian there. Yeah, very Australian in every other way.
That's pretty cool, eh?
Yeah. And that is a very good one. Thank you, Jason. Yeah. So I think
interestingly, I did my residency in Calgary. So I know Calgary very well. I spent about 10 years of my life there. Mm-hmm.
Oh,
great city.
Wow. Well, that's it, isn't it? It's a small world, and it's great that we get to connect online to be able to talk about things like this today. So let's get into a bit about this paper. Mm-hmm. Let me give everyone a bit of a rundown first before we start launching into the questions. So hip displacement is common in cerebral palsy and is less prevalent for children with spastic hemiplegia. We have always believed and understood that individuals with a Winter-Gage-Hicks type 4 gait pattern would have an increased risk of hip displacement, but the true prevalence has been unknown. In this retrospective cohort observation study, 144 patients with GMFCS levels 1 and 2 were followed for nearly 10 years, showing that hip displacement is higher than expected for all Winter-Gage-Hicks types, particularly for level 4. This has some significant implications for our practice, which we will get into right now. So, Jason, let's get into it. Can we start by first going through what hip displacement is and why it is something that we need to monitor in children with cerebral palsy?
Sure. Yeah, so hip displacement, it's second to ankle equinus or tight calf muscle. It's the second most common musculoskeletal manifestation in cerebral palsy. It's important because, well, number one, it's hard to detect without x-rays. It's silent until things get further along in your age. So when kids with hip displacement, meaning the ball is starting to come out of the socket, when they get older, that lack of connection or the lack of complete connection of the ball to the socket can lead to arthritis. And just like in older people who get arthritis, it leads to pain and impacts your quality of life. And it can also impact things like seating and can lead to things like decubitus ulceration. So it's an important thing. And, when in the earlier days, in the generation before mine, hip surveillance wasn't a thing. It was thought that, well, people with CP don't, if they're not walking, then the hips are going to be fine, right? Who cares if they come out? But actually we've since learned, after really looking at these kids over time, that hip displacement or subluxation leading to dislocation actually is painful in probably up to about 90% of kids who have a hypertonic motor type. So you have to, that's what's led to these surveillance type programs where we use serial radiographs, usually on an annual to biannual basis, to detect the hips as they start to come out of the joint at an early stage before we get to the arthritis, before we get to the pain. And, we try and treat it at that stage so we can give them a long life with a healthy hip that's pain-free. So that's the idea there. And that's why it's important to really detect it early, and x-rays are the key.
That's fantastic. Just a few things on that point. From a terminology perspective, we've spoken about hip displacement. How does that relate to often what we hear as subluxation or what are the other words that you use? Subluxation and dislocation. Like dislocation. We hear all these words, but can you give us a bit of context about where they actually sit?
Yeah, hip displacement is basically a term that encompasses subluxation to dislocation. When a hip is, and it also encompasses dysplasia without subluxation, which means that the acetabulum can be a little bit deformed and the head can be a little bit tilted out, but be very mild bit of displacement, versus if the ball is uncovered by about 30% or more, that's subluxation. But if it's completely uncovered, that's dislocation. So, it's really just a term that encompasses that whole spectrum of hip dysplasia in cerebral palsy.
That's important to note. And, the whole surveillance programs are trying to prevent that from happening, preventing pain and arthritis. What does happen when it gets to that point where, say, it wasn't captured and they do get pain and they do have a lot of arthritis? What are the treatment options at that point in time?
Yeah, it's a problem because unlike in typically developing adults who get primary osteoarthritis or secondary osteoarthritis of the hip, for example, and you're 65 or 70 years old, you've got some good options there. You can get a hip replacement, so replace the socket with plastic and the ball with a metal or ceramic. And that works really well. It has a long lifespan for the implant and is a game changer for quality of life. But for kids and adults with cerebral palsy, it's more difficult because spastic muscle contractures and weakness in abductor function and things like that lead up, and also bone quality is also compromised, so leads to high risk of dislocation and fracture. And so we usually only use hip replacement surgery in CP for kids who are very high functioning ambulators.
Right.
So in kids, for example, with hemiplegia, which we're going to talk about, some of those kids can be candidates for hip replacement surgery. But in other kids who are non-ambulatory, the options are less.
Yeah, sure. No, that's...
We typically need to remove the joint itself, a resection procedure, which doesn't have great reproducible outcomes.
Wow. Okay. So it just highlights the value and the importance of surveillance and understanding the natural history. I suppose before we get into this in too much more detail, can you talk about the relationship between hip displacement and the GMFCS levels? And let's really focus, I suppose, on our levels 1 and 2, but the full spectrum, I guess. What is the relationship there?
Yeah, I'm happy to. It's one of my favorite things to talk about. You know, I mentioned that I was in Australia before. I was a fellow at the Royal Children's Hospital in Melbourne under, a lot of great luminaries there. But I would call my forever mentor, Kerr Graham, Professor Kerr Graham there, really got me involved in what became a seminal study also in Journal Bone and Joint Surgery, called Hip Displacement and Cerebral Palsy. And in that, we looked at the incidence of hip displacement based on Gross Motor Function Classification System, or GMFCS level, which at the time was really new.
Yeah.
There was very few studies using the GMFCS. And so Kerr kind of stumbled upon it through, his collaborations with pediatricians and things like that, and said, we should really look at this with respect to hip displacement. And so I was one of his worker bees working through to help bring the study to fruition. And it really changed my career and impacted my whole career direction. So working with him and that study in particular. So in that study, we found that if you have more severe cerebral palsy by functional severity, so GMFCS level 5, for example, kids who are wheelchair dependent and have troubles with head and trunk control and are quite dependent for their care, your risk of hip displacement, meaning the ball is uncovered by the socket by about 30% or more, is about 90%. And as you get better in your function, that risk goes down in a very linear fashion. It was really exciting to see that perfect linear decrease with improving function. It was quite uncanny. Our jaws dropped, actually. So when you get down to GMFCS level 1 and 2, it was really 1 was 0, I believe, or 1 was 1% and 2 was 15%, if I'm remembering it correctly. And 3 was 42, and 4 was 70. I might be off on a percent or two, but I'm pretty darn close. Yep. So when you look at those numbers, 1 and 2 being 0, it was 0% actually, and 15%, you kind of go, okay, that's pretty small, but it's not 0. So maybe we still need to keep our eyes open for at least the level 2s. And we thought that hemiplegic they're usually 1s or 2s, and we thought they were pretty well protected from hip displacement. But after you're in practice for, it's my 23rd year treating kids with cerebral palsy, these things that you took as dogma come up and you say, wait a minute, you're not actually following the rules. You get a kid who's Winter-Gage-Hicks 2 or 3, and their hip is coming out of the joint and painful, needing surgery. And so when you see a number of those rule breakers, you kind of go, well, maybe the rule is not a rule at all, and we should look at this a little more carefully. And that was the impetus of this study. So when I say this is 20 years in the making, I've really been thinking about hemiplegia since that first paper we did in Melbourne.
Wow.
So it's kind of a cool thing to have those bookends.
Thank you for telling us about that. I remember, and it's so great to hear your perspective and your experience through that study. I remember hearing about that at a conference, hearing Kerr speak about it when I went to the Gait course. You know, it was such a seminal piece of work, wasn't it? That linear relationship, I think, I can only imagine what it would have felt like for you as a researcher to see the data for the first time. But I remember being on the other side going, whoa, that is amazing. And it just made us think so differently from there. Congratulations on all of that work, and thank you for following up with this study. It's brilliant. It's really interesting now to really delve into this group, like you said, where it was, GMF's level 1 and 2. There's a risk there, but it's not as high as we know, compared to 70%. So the Winter-Gage and Hicks is something that is commonly used, and that was the modifications to that were part of Jill Rodder's work as well, and Kerr Graham, about Winter-Gage and Hicks and the types. Do you mind just going through Winter-Gage and Hicks for us a little bit as well, for scaling from the 1 all the way through to the 4?
Absolutely, yes. Winters-Gage and Hicks were just the authors on a paper that looked at sagittal gait patterns, so looking at someone walking from the side with hemiplegia, and they found that they tended to walk with the sagittal gait pattern in 4 different buckets. One was type 1, which meant that you had the kid would have a drop foot when they were going through swing phase, so their ankle would go into plantar flexion, but they didn't have a contracture there.
Yep.
So when they put their foot on the ground, it would go flat again. 2 was basically almost the same thing, so plantar flexed during swing, but also plantar flexed during stance phase. So that was a true contracture of the calf muscle. Number 3 was kind of interesting, and I think is often misconstrued as just having knee flexion, probably due to a hamstring contracture, but actually Winter-Gage and Hicks described it as a stiff knee gait, meaning there was co-contraction of the rectus femoris and the hamstring. So actually in our study, we had to look carefully to make sure that that's why we used gait analysis, to make sure that we had these patients classified correctly.
Right.
And then the difference between 3 and 4 is that the hip becomes a problem. So the hip, it's actually hip flexion contracture, and the hip is in flexion throughout the gait cycle. So that's a 4. But it's only a sagittal classification. As we know, there's 3 planes or there's infinite planes, I guess, but 3 main planes we look at when we watch someone walk. And one of the more important ones is the transverse plane, of course. So torsional abnormalities around the hip, particularly the femur, and also in the coronal plane. So typically would be adduction, hip adduction. And so what Professor Graham and Dr. Rodda had done was they recognized that this was a very important part of hemiplegic gait, and also had implications for the hip and hip displacement. I was taught that, by Kerr years ago, but it was we mainly seemed to see it come up in Winter-Gage-Hicks type 4. But they modified the type 4 so that it had increased femoral anteversion or increased internal femoral torsion or internal rotation, and hip adduction as part of that. And they also added pelvic retraction, I think, was also part of that. So those things really brought the other planes into it. They didn't, that was back in 2001, so a long time ago. And I thought that was a very important paper, but they didn't add those modifiers in the transverse and coronal planes to the other Winter-Gage types. And I guess it was assumed that it wasn't as big a problem for them. And certainly if you look at the hip surveillance protocols globally, there's talk about Winter-Gage-Hicks type 4, but no talk about the other Winter-Gage-Hicks types. So I think that Kerr and Jill were very much on the right track. And my hope is that after this, I actually want to approach them and say, hey, do maybe we could add the modifiers to all of your types, and we'd have a very complete classification. So I might be given a spoiler for what I wanted to come from this paper, but that's kind of, and this kind of influenced me as well.
Yeah, no, it's the perfect lead into this actual study now. So can you tell us a bit more about the study design itself? What did you actually do, and I guess what context was all of this data collected from?
Yeah, well, I just want to take this opportunity to say that I'm probably the luckiest CP doc in the world, because I got to work in Melbourne with the great team there, Professor Graham, Jill Rada, Pam Thomas. They were all my mentors, and others. And when I went to the United States in 2019 and got to work with one of my other great influences in CP, with Dr. Freeman Miller, and working with my longtime friend, and I would call him a mentor too, even though we're the same age, Dr. Wade Schrader. So, I've just been so lucky to get to work with those in those two major centers. So I kind of stole a bit from both of them. So when I was at DuPont, or Nemours Children's Health, it is now, in Wilmington, Delaware, we wanted to look at this question. And so we queried our very large gait analysis database and our CP database to get kids who had hemiplegia, who were from ages, I think it was 5 to 18 was our age range. And they had to have at least one gait analysis. They had to have at least one hip surveillance x-ray, which is not always that easy in hemiplegia, because if you listen to the surveillance protocols, you do a screening x-ray at age 6, and then if it's fine, then you shouldn't x-ray them again. But but Dr. Miller was never a rule follower, so he used to x-ray them more than what other people were saying. And also, for the ones when we couldn't get any x-rays, we would have to look at things like abdominal x-rays and different things like that, scoliosis x-rays, just to try and get enough to fill that out. So we were lucky we were able to do that. So they had to have at least one hip surveillance x-ray, but the kids had many more than one. And we screened, I think, 220 odd kids from that met those criteria. And then after going through our patient flow and our inclusion-exclusion criteria, we ended up with 144. And that's what we did our analysis on. Retrospective study, but at a center which is, really takes in kids from all over the United States and even outside the United States. It's not a population-based study, unlike in Australia, where you have, state-based registers, and even in Canada with British Columbia with the provincial register. We have one in Nova Scotia as well, which is not as well publicized, but we'll have to change that. So it's not a population-based, but it does represent a big population of CP. And in this area, people don't usually move around too much. So we do have a bit of a captive audience. So I think we've done a pretty good job, but it's hard to say we can generalize it everywhere. But I think it gives us a pretty good idea of maybe what we should be doing next with respect to hip surveillance for these kids. And
with this group, what was your primary outcome that you were really looking at?
Yeah, our primary outcome was radiographic. We were looking at the primary outcome was the development of hip displacement, which was defined as a migration percentage of greater than 30%. So what a migration percentage means, it just means the amount of uncoverage of the ball with the socket. So if it's uncovered by 30%, that's a migration percentage of 30%. So we looked at that, and the other part of that primary outcome, which we call the unsuccessful hip, was having the 30% or more or having surgery for hip displacement, which usually is cutting the bones and putting the ball back in the socket, reconstructive osteotomies. So that's what we had as our primary outcome.
Okay, great. Now the all-important, we've been waiting for this, the results. Tell us, what were your main results? Over to you to go through that?
It was a bit of a surprise. And I love when we do research which surprises you, because you have these deep-seated notions about what should, hemiplegic, kids with hemiplegia, unilateral CP, they don't get hip displacement. Don't worry about it. Don't x-ray them, say hi to them every now and again. If they get a tight calf, help them out, But we're not thinking about the hips that much. And, but like I said, after seeing those kids come in that weren't supposed to come in, we knew something was up. But when we got the results, we found that, Winter-Gage-Hicks 4, so those with hip, knee, and ankle involvement, did have the highest risk of hip displacement, about 24%. Wow. But what was really surprising was that Winter-Gage 1, that was just a drop foot, that had a risk of almost 10%, 9.5%. Winter-Gage 2, that's a tight calf only. That kid also had a risk of about 9%. And for some reason, the type 3 had one of 7 or 7.5% or something like that. Wow. So, but they really, I would have thought they'd had nothing. That's what I always thought. So I love it when things kind of challenge what you think is dogma. So it kind of confirmed our suspicions. And then the answer is, why? Why would it be that a kid with just a drop foot is going to have a problem with their hip? But we know there's much more to hemiplegic CP than just a drop foot or even just a tight muscle. There's issues related not only to what we call the positive aspects of CP, but the negative ones. This is actually Kurt Graham speak now. The negative aspects, which are things like weakness, loss of selective motor control, and balance issues. So these are all different things. So there's still abnormal acquisition of function that happens during development in kids, even with very mild hemiplegia. And that has an impact on the skeleton. So we found, for example, that even though you were Winter-Gage-Hicks 1, you still had, I can't remember the percentage on this, Dana, but you still had a fairly high risk that you were going to have your femur twisted inward. So having an internally rotated hip. You also had a risk that you were going to have an adducted hip. And so when we looked at those risk factors across the board, we found that after doing a logistic regression analysis, found that actually those things, the coronal plane, the hip adduction, and an internally rotated hip, those were two independent risk factors for developing hip displacement. So it was very much in line with what Professor Graham and Dr. Rada had said back in 2001 when they added those descriptors to Winter-Gage-Hicks 4. The difference with our paper is that they apply across the whole spectrum of hemiplegia and not just type 4. So I think that was the big surprise. Very cool.
It is very cool. There's lots, like my brain has so many questions now. So Dana, just think about your questions logically. Here I go. Obviously, what this means is Winter-Gage-Hicks, 1, 2, and 3, and we need to talk about Winter-Gage and Hicks, I think, a little bit as well, but Dana, park that idea. Clearly, there's still some issues when it comes to hip internal rotation and adduction that might not be as obvious as your 4s. Because I think of, when you're training and when you're learning about these classifications and you look at the videos, the 4s are so obvious, right? You've got this really retracted pelvis.
Yes.
And, you go, okay, it's pretty severe. It looks like someone that does have probably bilateral spasticity, but there's really an asymmetry here that we can see. And then as a result, when you compare it to 3, 2, and 1, you might see a little bit of in-toeing, but you're like, oh, it's probably not as much as a 4, but you do know that's there. And I think of the conversation we had with Dr. Bhuma Ravamutham, and they were looking at, instrumented gait analysis in clinic, and it's the in-toeing that is kind of the biggest sign that there's dystonia, there's positive signs there. But as a result, if you have all these positive signs, it does mean that the negative signs, the weakness, the actual amount of physical activity they're able to engage in, to be able to have that variety of movement that the musculoskeletal system needs, there is a deficiency there. But we've probably underemphasized it because we've always been thinking about the Winter-Gage-Hicks type 4. So my question there for you is, in terms of the positive and the negative signs, which I'm really big on. I love that paper. I can even see that diagram right now. It's a great diagram to think about what's influencing the body. We've always had this emphasis on positive, as in there were the swash braces, there was the muscle lengthening, there was botulinum toxin to reduce spasticity. But I felt like the negative was never really emphasized enough. And I think we probably, what are your thoughts on that? What is the influencing factor here on the hip for these kids who are actually relatively active compared to your Winter-Gage types Hicks and 4?
I think this is a whole other podcast. Are you sure you want me to go down this road?
Let's go. I can't. Yeah, let's do it.
I'm just kidding.
Because there's a lot to this, isn't there?
Well, there is. And one of the things that you had said it, maybe the Winter-Gage-Hicks classification actually almost made us put kids into these boxes and where you don't see the other aspects that are there. And I do think it's these negative aspects that have a role. But so, for example, for a child, we did this with gait analysis, right? So we can see whether they have true internal hip rotation or not, whereby a child who has good selective motor control, good trunk selective motor control, might be able to pull their pelvis back and hide that from you in a clinic.
Yeah.
So their knee points perfectly forward. Yeah. And they're going quite fast. So, without gait analysis, you might miss that, even if you're very experienced. I know I do all the time. So I think that's part of it, selective motor control. But the other question is, why do these hips come out of the joint at all? And, back, I would say the father of hip surveillance is a guy from Toronto who unfortunately passed, great teacher, Dr. Mercer Rang, who recognized that hips could be a problem and that we needed to do surveillance for them with radiographs, but he also said that it was because of tight spastic adductors and spastic hip flexors that was the problem, and that was kind of putting the hip in that position to have it come out of the joint. And so if you do a simple little tendon lengthening procedure at the right time, then you interrupt that pathway to hip displacement, and then you're golden. But actually, we found now over the years that simple thinking about treating the positive aspects, whether it be by surgery, surgical lengthening of adductor, or botulinum toxin to adductor, or whatever you do to an adductor muscle, it didn't seem to change the trajectory. And these kids were getting hip displacement anyway. And so you say, well, why is that the case? So there must be something else going on. I also treat kids with spinal muscular atrophy, for example, who have no spasticity. They're actually low tone, very low tone. And their hips actually come out of the joint too, and they look almost identical to kids who are GMFCSL 4s and 5s. So why is that the case? And so, we've been looking a lot at this, and there's quite a few papers that we've written about the etiology of hip displacement now. And I actually think it's rooted in these negative aspects, the lack, the abductor weakness, the lack of ambulatory function, and the difference in the hip joint reaction forces, which typically guide our bone growth, are not there in a normal sense. So all these things are the reasons why I think that even in somebody with hemiplegia, it's very high functioning, those shifts in the typical development and the way that muscles fire and how they coordinated and these sorts of things, I think that must be one of the reasons why we're still seeing these things, even when it looks like everything else is just about there, So it's still an area of study that I think we'll keep looking at for quite a while. But that's where I think it is going. And if you're interested, there's just Google me. You'll find a lot of my thoughts in some of those papers, as well as some really great thinkers that I get to work with.
No, that is great. And I think you're so right. These are things that I think we've been thinking about and noticing. For sure, it's one of the really simple measures I do, for example, clinically, is the symmetry ratio, right? Where if you don't have instrumented gait analysis, you might still have a gait analysis where you can measure how long they spend in stance, for example. And there is in a study that I was part of, that I did as part of my PhD, I looked at time and stance asymmetry ratio. And it was something like 0.7 to 0.8. So their children spending, as a symmetry ratio compared to 1, far less time on their more hemiplegic leg. And with each step, that tells you a whole lot about how much stability they have in stance. It tells you about how much extension they can actually achieve. And we know these kids often don't get up onto their feet. Whilst they get up on their feet before your other GMSS levels, there's still a delay in the time it takes them to get up and move and do all those lovely weight shifting. So I think there's a lot there that as a physiotherapist or a physical therapist that you can think about and make sure that for these kids, you are prioritizing movement just as much as you would for any other GMSCS level. And the assumption they're going to be on their feet is one thing. But this has definitely got me thinking a lot. From your perspective, what would you like to see change, influence in the systems that we currently have? Like, what can we do right now?
Well, I think the systems that I think we were targeting with this paper and the question that was raised was really geared towards hip surveillance protocols. There's still quite a bit in the hip surveillance protocols that are still just expert opinion and consensus. And one of those areas was in hemiplegia. So right now, for example, in the Australian hip surveillance guidelines, which is really the mother of all the other guidelines, in my view, it talks about Winter-Gage-Hicks as being at risk for hip displacement, but type 4 only. And so I think that I would like to see it just those guidelines to include that, okay, we have some evidence now that actually would support that, it's not just Winter-Gage-Hicks 4, it's anybody with spastic hemiplegia who also has things like internal hip rotation and or adduction is somebody you should really be thinking about. And the other thing is to maybe not cut off hip surveillance at age 6 or 8 or whatever it is in there now, but recognizing that when these hips come out of the joint, it's typically during the adolescent or pre-adolescent growth spurt. And so if you cut off your hip surveillance early, you're going to miss it when it happens. So just have a little bit higher index of suspicion and really think about the kids rather than just saying, okay, they don't get it, so don't worry about it. Because if it goes for a long time, sometimes it's hard to get those hips into a good situation where they can be preserved. And sometimes we can't, they're gone too far. So that's what we want to avoid.
Absolutely. And you think about the potential impact of what these surgical procedures might look like. It's quite impacting for someone who is normally very ambulatory and might be moving around themselves. And so the recovery time following from that as well will have a significant impact. Can I ask you about Winter-Gage and Hicks then? Like, that's something that is just, we all know it. It's something that we've used for a long time. But sometimes, like we sort of alluded before, classifications can make us think a little bit into these boxes. Is there any other classification tool that we should be using? Is there anything else that we could be thinking about? You spoke a little bit earlier about maybe updating, the Winter-Gage and Hicks to including that across the board. But yeah, what are your thoughts on that right now?
Yeah, I with no disrespect to Dr. Gage, he's another person I really admire. But Winters and Hicks, I think Dr. Hicks is a sports doc now, so he probably doesn't care too much. But I would just say that it's a good start. You have to start somewhere, but I don't think it really is a great classification for hemiplegia. It doesn't help me that much. The only reason we picked that classification for this paper is because that's what was referenced in the hip surveillance protocols. In practice, I think about the Rada-Graham classification when I see these patients because I'm looking for these coronal and sagittal, coronal and transverse plane abnormalities we talked about. So I'd probably like to see the Rada-Graham classification be updated to include modifiers for the other types. I think that's what I would like to see. And then just so it makes people think about, okay, don't just think about the sagittal plane and forget about the hips. If you see these other things, you got to be thinking there might be something else going on at the hip as well. So that's what I would like to see. a higher index of suspicion, and I like to see it just a little more emphasized in surveillance protocols. So hopefully our work will have some impact there, or someone else will replicate it and give it even stronger evidence. That would be lovely. I would like that.
Yes. No, that'd be absolutely wonderful to see, because the numbers, like you said, are surprising and they're not what you would expect at all. So what does this mean now for you and your work? Is there anything that's coming up that you're working on at the moment? Anything else that you're expanding on, Jason?
Yeah, I'm very much a hip nerd, and in CP, not only the hip, I and also a muscle nerd. So I like to understand why things are happening. I'm not really content with just knowing that they're happening, And so when things don't quite make sense to me, I feel like we need to figure out why. And so most of my research questions are things that I really want to know. So I'm trying to sort of tick those off. And in the hip world, I'm really interested now about why hip displacement develops. And we're getting more, I think we're getting closer to that with looking at work that's not only in CP, but compared to other neuromuscular conditions, which go down similar pathways.
Yes.
So that's been really interesting. And now we're looking at, if we do surveillance and you pick up hip displacement in a kid's 3, what do you do with it? I just told you earlier that this doing Botox to the adductors or releasing the adductors is not going to do it. So do you do this big reconstructive osteotomies on this kid and then have a risk of having to do them again later? So I don't think that's the right way to go. So what we've been doing is really looking at how other treatments like guided growth can help, something that's minimally invasive and can reverse some of those changes we're seeing in the geometry of the shape of the hip. And in doing that, we're actually learning a lot about what those geometric changes actually do to cause hip displacement. So by reversing them and seeing the hip improve, kind of goes like the corollary of, if you can't prove the truth, you prove the corollary. So then you figure out what the answer is to your original question. So I think that's kind of where we're looking right now. So that's interesting. We're at the early stages of that.
Fantastic.
So yeah, that's where I'd like to go further.
That's fantastic. All of that. It's just such important work, isn't it? Because it has such a huge impact on not just the individual lives, it's the family and the community around them as well. It's a massive impact. So I look forward to more of that work, Jason. So I'll definitely be keeping in touch and following very closely. Thank you for giving us a sneak peek on things to come. We are not finished just yet. I can see him getting ready. So let's head into our final segment. Jason, brace yourself. Here is our confident Dutchman coming on to the pod now. Tell it to Ed. Ed, as you know, is our producer. He doesn't have a background in child health, but he has been listening. I think he's been taking some notes, and he often comes up with some really interesting questions from his perspective. So before Ed has an opportunity to ask you a question, Jason, I'll get you to summarize this work in about 60 seconds or so. And Ed, you'll have time for one question. Take it away, Jason.
Well, thanks, Dana. Our work has really shown us that when you see a child with unilateral cerebral palsy or hemiplegic cerebral palsy, in the past we didn't think too much about the hip, except for when there was more severe involvement. But I think what we've learned from this study is that you need to think about even the lower end of the functional severity scale and really think about those things like internal hip rotation, hip adduction, that as risk factors to look for and to prompt you to do hip surveillance x-rays and treat these kids at an earlier time so you get better outcomes for them. And so that's what it's all about. So higher risk than we thought, 10% even in Winter-Gage-Hicks 1, 24% in level 4. And if you have internal rotation and adduction, then you should really get an x-ray for that kid.
Wow. Fantastic. A wonderful summary. Thank you so much, Jason. That was brilliant. I love a good summary. All right, Ed, over on to you.
Great conversation. As usual, I tend to find the paper and try and have it up on my screen as I'm kind of learning something new for the very first time. But I guess I'm intrigued by this because Dana seems very excited. I'm trying to kind of go through the paper, but I'm assuming that the study relied on a dedicated, detailed 3D gait analysis, like in a lab setting.
Yes. Yeah.
Yeah, that's right, Ed. Yeah, it did. Yeah, which limits its for people who don't have that, you would say, probably.
Yeah, so that's actually where my question was going to go. I guess okay. I'm an IT guy. I know nothing about the human body, but I'm learning through the course of 300-odd episodes of the pod. But I guess not every clinician, not every family or even university, I guess, or hospital might have access to 3D gait labs. And with new machine learning tools, like a lot of AI, there's been a lot of movement in the 2D gait applications. And now there are things like pose to sim, which allows you to use multiple cameras, like 2D cameras to find a skeleton and convert it to, say, like a C3D format that can then be analyzed in a 3D space. I'm just wondering, with all this technology, does it mean that we're looking now at a future where these kind of like more affordable, democratized tools kind of allow for better screening or potentially kind of catching problems before they become like a serious problem?
You know, I think that's a really good question. And you hit the nail on the head with respect to where we're going with gait analysis. What you're alluding to are markerless systems, whereby you basically just have, cameras. Kid walks down a hallway. There's been some research looking at green screen technology for that, for example, to help with that. And certainly we've been trialing some markerless. We're doing research on markerless systems here at Dalhousie. So that would be a great thing, and it would be something that potentially would have broader implications for people who don't have gait analysis. But gait analysis, is fantastic and is the gold standard, but you need to have very dedicated people who have a lot of training, who can put these little reflective balls you see, when you look at the special effects for Lord of the Rings or something, they put them all over their face. So we put them on people's bodies, but they have to be put in very precise places and very reproducible. And it's hard to get people to have those skills. It takes time to acquire them. With a good markerless system, if we can show that there is that concordance between the gold standard and a markerless system, I think it would open up, and AI is probably going to be one of the avenues for that. I don't think we're there yet, but it probably won't take too long. And then instead of us having to use these gait labs with all those resources, you could just take a little smartphone video and let's say, hey, that's whatever classification 1, 2, 3, and 4 that incorporates more than just the sagittal plane, right?
Wow.
So that's where I think you would like to go, right, Ed? Sounds like.
Yeah.
Look, I think that the technology obviously needs to have an endpoint, and hopefully like it kind of assists people to make these kind of decisions.
There has to be a point to it. Yeah, that's right. Yeah. It's interesting, Jason, because
for sure.
We didn't get to talk about it today,
Good
but
question.
it was mentioned in your paper was hip screen. There are tools and apps that we can use to guide what we do. Wouldn't it be interesting? Wouldn't it be amazing if there was an app like that where once we're at the stage where we've got instrumented gait analysis through a reliable form that has AI, whether that could actually help to, funnel the kids in the right direction, and have as a standard of care. That's why I think this work is so important.
Yeah, for sure. We've done some machine learning studies based on our instrumented gait analysis to try and do that very thing, have predict what aspects of the gait deviations lead to the biggest functional issue, and whether our surgeries can actually, what surgeries do we need to do to correct that? So we have done some work, actually we just published that very recently, that looked at the prediction of using machine language models. But again, that needs full instrumented gait analysis. So it would be really cool to go full markerless and have the machine learning that tells us all those things. I think we will get there.
Yeah.
There's a lot of people working on that right now.
Yeah, there's a lot of hope. That's very exciting. Great question. Thanks, Ed. I had a feeling that's where you were headed. Yeah. Jason, thank you so very
Kind
much.
of IT as well.
It was very IT, yeah, that's right, yeah. And yeah, I think he is looking very proud of himself. So we just built his confidence there, Jason, and we'll see what happens with that. Thank you so very, very much for joining us on the pod today, for taking us through this paper. It really is just going to be one of those papers that will be referred to. It's going to change thinking. So congratulations to you and your team for getting this work to where it is right now. And we look forward to hearing about all the other work that you're embarking on. So we will stay close to all of it, and I'll make sure we get another chat with you again soon. But also thank you to your family for everyone staying in their rooms and allowing us to record this podcast late at night for you. So thank you so much, Jason.
It was my absolute pleasure. It was a lot of fun. And thanks for the
Absolutely
invitation.
welcome. To all of our listeners, I hope you really enjoyed that. This is an open access paper, so I'll make sure I link this on our website. So we do have two websites, researchworks.net, which has a summary of a lot of these papers that we're talking about, but we are migrating everything to researchworks.academy. I remember there's a lot of free resources we have there, including instrumented gait analysis. It's 2D, where you can have some great videos that you can take. There's also decision trees to work out which gait classifications you might be looking at. So you might want to think about that as you're listening to this particular conversation, as you're learning more about these gait classifications. So hope you can all tune into that. But for now, we'll talk to you all again very soon. Goodbye and talk to you soon. Bye. Bye, everyone.